I want to thank you, Felicia, for your kind invitation. When you invited me to come to Siena to give a lecture, I was very excited, so there was very positive stress. When you asked me to give a lecture on stress and infertility, I was less excited, since it was not part of my repertoire. But when you told me that it was at the same time as the paleo, I was very excited again. So I bought my ticket just in case you changed your mind. So here I am, stressed to talk about stress and infertility. I had to learn a new lecture, and thanks to all the speakers here, I learned from all of your publications, and so here we go. This is my disclosure. I really don't have much to disclose. I'm participating in some clinical research studies sponsored by AbbVie, evaluating GnRH antagonist on management of endometriosis-related pain, and with Bayer evaluating some selective progesterone receptor modulators in the management of AMENORRHEA, none of which have anything to do with the topic today, so there are no conflicts of interest for me to disclose at this point. The objectives of my talk today are first to talk about the stress that's associated with a diagnosis of infertility. This is an acute stress, it's a temporary stress, it's very real, however, and in fact one of my associates, whom you probably know from the literature, Dr. Susan Klock, who worked with me several years ago when we started our IVF program at UConn, has reported that just the diagnosis of stress and the evaluation of stress can cause depression in up to a third of patients. So it is a stressful situation which needs to be evaluated, acknowledged, and managed. When you do so, then the patient will become more compliant, the quality of her life and the relationship with her husband will improve significantly, and perhaps the results may improve significantly as well. However, again, the goal here is to treat infertility, because once you've done that, the stress will go away. The second part of my talk will be on infertility when it is caused by stress. This is totally a different problem. It is a much bigger problem to address, and it doesn't go away once you've treated the infertility. In fact, we can easily treat the infertility in many of these patients by inducing ovulation, etc., but that doesn't address the underlying psychological, psychosocial, and metabolic dysfunction that's caused the infertility to start with. So the reproductive endocrinology and the infertility specialist, when he's faced with infertility related to stress, he must not focus on infertility at all. He really must focus on stress to relieve that stress. And once he does that, or she does that, and if it's done successfully, then infertility may not need to be treated at all. And if it needs to be treated, it will be much more easily treated. Here is the most recent textbook of Fritz and Spiroff, formerly Spiroff et al., which states all of the potential causes of infertility, both in couples as well as in women. And these are well known to you. I don't need to go through them. And they include the male factors, and then tubal factors, ovulation dysfunction, etc., etc. You notice there is no stress on the pathophysiology of infertility from this. In fact, if you look at the index of this textbook and you look for stress, you're not going to find it. Only when we look at an ovulation, there is a small chapter on stress in an ovulation, but not on infertility, which is interesting. Yet stress plays a major role in infertility, not only in terms of adversely affecting the quality of life, but also in terms of making it more difficult for the couples to get pregnant. So stress is a very important topic, and it is a major problem for couples with infertility. Barbara Manning is the founder of Resolve. Resolve has been a support group for infertility for many, many years. It has done a lot of wonderful things in helping couples with infertility to reduce stress and to look for better ways, therapeutic ways to improve their fertility or to manage their infertility. She describes infertility as a crisis of many dimensions. The suffering and the stress of infertility rivals that of any physical problems. This is not something that's appreciated by couples who don't experience infertility. Many couples, the majority of them, have no problems getting pregnant. In fact, many of them get pregnant when they don't want to get pregnant. But for the couple who's trying to get pregnant after the first 3-6 months and pregnancy does not occur, there is a great shift in how they feel, how they behave, how they perform, and then infertility becomes the major focus of their lives. They become emotionally depleted, and it is a major impediment to their life plan. When you look at some of the studies looking at infertility and stress, this study by Domar showed that infertility has been ranked as one of the greatest sources of stress in a person's life, comparable to somatic diseases such as cancer. And in addition to the infertility itself, the infertility evaluation and treatment adds significantly to the stress. And in fact, in these two studies, they've evaluated couples with infertility during their treatment, and the couple stated that infertility treatment was ranked second to major tragedies of their lives, such as divorce or death. So it is a very stressful situation. Most of these studies have been published in the past on Caucasian couples. A very recent study addressed the Afro-American population. This study was just very recently published in June of 2015 from an investigative group from Michigan. And Afro-American women with infertility, they feel isolated, they withdraw, they feel a sense of, decreased sense of self-worth and gender identity. Some of them feel like they are failures because they cannot have a child. So it is a very major, stressful time for them. Infertility, like any stress, will result in the body response of flight versus fight. The fight-aggressive couples will may say to you right away, okay, so we have infertility, let's get on with it, give me the best treatment as soon as possible, and go for it. Unfortunately, a lot of the infertility specialists fall for that, and they indeed offer and implement the most aggressive therapy, frequently in vitro. And in fact, unfortunately, in the United States, most of the REI, i.e. infertility specialists, have become really IVF specialists. That is mostly what they do. They do very little else, such as reproductive surgery, or very little of the other stuff, okay? But that's not probably the best approach for these couples. It is very important to counsel them, advise them, and to lead them to the most appropriate therapy for them, which may not be the most aggressive and may not be indeed the best one. Other couples will respond with flight, and that includes withdrawal and isolation from family and friends. They become depressed. And because of that, they become less compliant. They will resort to drugs and alcohol. Their eating habits may change. Their marital relationship may suffer significantly. And that, unfortunately, makes the infertility management somewhat more difficult and many times less successful. So stress reduction in couples with infertility is extremely important, not only in the improvement of the quality of their lives and their marital relationships, but also in adequate assessment of what's going on, what the problem is, find the cause of infertility, and treat it specifically and appropriately in the most nurturing way to reduce the stress, improve compliance, and finally to improve results. The ASRM offers many or several stress reduction techniques, which are listed here on the left side of the slide. And indeed, they are very, very useful, and they will work, and they will improve things. But I think that the most important technique is that which we as infertility specialists can offer the couple the very first time that we meet them, okay? Engage with them in a very thorough discussion of the basics of infertility. Tell them that they're not alone. Tell them that at least 15% of couples will suffer from some sort of infertility. Usually we can find a cause for it, correct it, and usually we can find a resolution with it. It is very important to point out to them it is not their fault. It is not a punishment for something they might have done some time ago when they were teenagers. It is not his fault, it is not her fault. Include them in your team and make them part of the team, i.e. the nurses, the technician, the ultrasound technicians, etc., so that they will feel like they're part of a team and that we are all working with them, and that will go a long way in decreasing their stress, in improving compliance, and eventually to get rid of the stress. And the only way really to get rid of this stress that's associated with infertility is to come to a conclusion of their infertility, and hopefully with success. Okay. The stress associated with infertility is an acute stress, and once the infertility is resolved, the stress usually resolves as well. Okay? That is not so with infertility when it is caused by stress. This is a major problem, and here again, I want to re-emphasize that the focus for the specialist, infertility specialist, should not be on infertility per se, but should be on relieving the stress, identify the pathophysiology, the abnormal dysfunctions that are going on in the patient, which have been very well described by Dr. Berger earlier today, and address those issues. And once you've done that, then the problem of infertility becomes much easier and much likely to be successful. Stressful stimuli of this type can lead to a variety of secondary diseases, which include depression, cardiovascular disease, and a variety of other problems, including, obviously, reproductive dysfunction. Women with significant stress also have a higher level incidence of eating disorders, dysfunctional attitude about eating, obsessive attributes, especially excessive exercise, etc. And indeed, several studies have suggested there may be a link between stress-related psychiatric disorders and reproductive dysfunction. The infertility associated with this kind of stress is usually associated with hypothalamic anovulation and perhaps amenorrhea. It is the stress that suppresses the hypothalamic by increasing CRH, and that in turn will increase ACTH and cortisol levels and endorphin, all of which will result in decrease in GnRH production and decrease in LH. So that the evaluation of hypothalamic anovulation amenorrhea is really a diagnosis of exclusion, and you must rule out CNS problems, including hypothalamic lesions. They're associated with low LH and FSH levels, low estrogen levels, usually normal TSH, but Sarah corrected me with that, so Sarah would like you to correct Dr. Spiroff on that indeed there is a hypothalamic hypothyroidism, but prolactin levels are usually normal. ACTH and cortisol levels may be elevated. They usually are, in fact, elevated. And in fact, as shown by several investigators, and Dr. Petraglia himself showed that in rats that elevated CRF decreases LH secretion by inhibiting GnRH. In women, the manifestation of hypothalamic hypogonadism are expressed by ovulatory dysfunction, irregular periods, and up to amenorrhea and hypoestrogenemia. In men, if they have infertility and we address their infertility problem, then we will find abnormal sperm patterns, including oligospermia, asthenospermia, azoospermia, or all of those. When fertility is not an issue in these men, then they may present with decreased libido, diminished muscle mass, altered hair growth, etc. The mechanisms by which chronic stress might influence reproduction include a variety of different patterns that already have been discussed. It's not only hypothalamic pituitary problem that leads to anovulation, but there are local effects of catecholamines in the uterus and other immunologic and inflammatory issues that may prevent not only ovulation, but also fertilization itself and implantation as well. In men, psychological stress at an extreme has been shown to significantly affect sperm quality as well as quantity, as we mentioned earlier. When stress is present, even if couples do get pregnant, then their pregnancy outcome may not be very favorable. And in fact, this study that was published in 2012 looked at women with a history of repeated miscarriages or recurrent miscarriages and compare them to 40 age-matched control, evaluating them for stress status, utilizing a variety of stress parameters as described over here, including the FPI, the PSS, PAS, and NAS surveys. And what they found was that women with repeated miscarriages had significantly higher scores in these stress surveys. They were statistically significant compared to similar patients, women who were not affected by repeated miscarriages. They had higher scores in FPI, in PSS, and negative affective scales, but they had lower scores for positive affective scales. There were no difference, however, when they looked at peripheral CD and dim and CD bright NK cells, and there were no differences in their serum or salivary cortisol levels, nor in the cortisol suppression after dexamethasone suppression test. There was a little association between psychological stress and measurements of biochemical measurements as shown over here. So that stress may indeed result in, as a risk factor for recurrent miscarriages, poor implantation, etc. The hypothalamic hypogonadism associated with stress display a variety of neuroendocrine secretory aberrations, as already mentioned by Dr. Berger, in terms of hypercortisolism as well as hypothalamic hypothyroidism. Unfortunately, this neuroendocrine dysfunction will not resolve by just merely resolving the process of infertility. And so that even if you do induce fertility in these couples, there are consequences during the pregnancies which may lead to abnormal pregnancies or abnormal fetal growth and abnormal fetal development, and eventually it may also lead to abnormal nurturing and child development. Therefore, the focus of the management of stress-related hypothalamic hypogonadotropism should not be on fertility, but should be on the underlying psychosocial and metabolic dysfunction. Focusing on that will promote healthy eating habits, encourage healthful lifestyle, will dispel maladaptive attitude regarding body image, and implement behavioral strategies to promote health and reduce stress. Once this is accomplished, then the infertility issue can be more easily and more safely addressed. So this problem is not just isolated disruption of GnRH and reproductive compromise. It is associated with a variety of other metabolic problems which will increase the risk for cardiovascular disease, osteoporosis, depression, psychiatric conditions, as well as dementia. And although we can restore fertility, as I mentioned earlier, that should not be the focus. The focus should be, and if I may use and quote Dr. Berger's statement here, that behavioral and psychological interventions that address problematic behaviors and attitudes have the potential to permit resumption of full ovarian function, along with the recovery of the adrenal, thyroidal, and other neuroendocrine aberration. Full endocrine recovery potential offers better individual maternal and child health. And that's really, really important. In conclusion, stress related to infertility is an acute problem that needs to be addressed and to improve the quality of life, will relieve the suffering and improve pregnancy outcome, but it is self-limited, and usually it resolves with the resolution of infertility. On the other hand, when infertility is related to stress, this is a chronic and a more severe problem that needs to be addressed before the issue of infertility itself, in order to improve both quality and quantity of life, both for the mother and for the children. Goals then are reduce stress, key. That will lead hopefully to ovulation, to a healthy mom, to a healthy baby, and eventually to healthy children. Thank you very much for your attention.